Hi, everyone. My name is Sue Balawani. I'm a PGY2 in the internal medicine program.
Hi, I'm Jason Matos. I'm one of the non-invasive cardiologists here at BI and a Bloomgard firm chief.
Welcome to our second session of our EKG curriculum. Today's session is going to be on LVH, RVH, and strain. So the goals of this session, the objectives are to gain a conceptual understanding of the different EKG changes that we see in LVH and RVH, to identify LVH and LVH with strain, to also identify RVH and associated abnormalities, and to create a differential for an R to S ratio greater than 1. We'll get a little bit into what that means later. So starting with the QRS complex, I want us to go back to something we covered in our last session. The QRS complex is firstly made up of the Q wave, which represents depolarization of the upper septal area, and this is sort of traveling towards the right side. Then we have our R wave, which is depolarization of the main portion of the left ventricle, and then the S wave, which is the upper posterior portion. Now, this QRS complex can look different based on which lead we're looking at it from. So for example, if we're looking at our anterior septal leads, the main component of the QRS is made up of this yellow arrow, which is the depolarization of the main portion of the left ventricle. So you can imagine that if this vector is pointing away from a lead, so for example, it's pointing away from V1 and V2, we expect to see predominantly negative deflections, which is what we see in our early leads. And then in our later leads, where this vector is now pointing towards, we see more positive deflections. And so this is the concept of why we expect to see R wave progression as we're going through our anterior septal leads. And understanding this will be helpful when we're talking about LVH and RVH. So LVH is caused by pressure or volume overload that results in hypertrophy of the ventricle. So what this looks like electrically is that there's an increase in the normal vector generated by the left ventricle. So going back to our picture here, basically this yellow vector that we're seeing, that's a depolarization of the main portion of the left ventricle, is going to be increased in amplitude. So conceptually, you can imagine that what that would look like is that in these leads, which this vector is pointing away from, you'd expect to see more negative deflections. And then in these leads, which this vector is pointing towards, you would expect to see more positive deflections. You'd also expect to see the same thing in AVL because this vector is pointing towards AVL. So that's the basis of the LVH criteria. You see these deep S waves in our earlier leads, and then tall R waves in our later leads, as well as AVL. So if you remember this, this is helpful when we go through all the LVH criteria that you're going to see. So the first LVH criteria is the Cornell criteria. So here we're adding the S wave in V3. And remember, we expect this to be deep with the R wave in AVL, which we expect to be taller. And if the sum of that is greater than 28 in men or 20 in women, that's consistent with LVH. Some other criteria, we have the Sokolov-Leon criteria, and similar concept. We're looking at our S waves in our early leads, adding it to the R waves in our later leads. And if the sum of this is greater than 35, that's another LVH criteria. Here you want to use whichever S wave is deepest between V1 and V2, and whichever R wave is taller between V5 and V6. And then we have a whole host of other LVH criteria. So if you have any precordial lead that's greater than 45, if the R wave in AVL is greater than 11, R wave in lead 1 is greater than 12, and if the R wave in AVF is greater than 20. Jason, do you want to help us sort of sort through all of these criteria and sort of what do you find most helpful in clinical practice?
Yeah, that's a good question. None of them are perfect if you actually go back to the one more previous slide, the Cornell criteria. The sensitivity of these are poor. This being the most sensitive up to 35 to 50%. So what I try to emphasize to trainees is that you should not memorize these. They're nice to know about, and really what a lot of these are emphasizing is exactly what you point out too, but that when you have really high predominant voltage, that you should be on the lookout, especially in these patterns that you're talking about. You should look out for LVH. One thing that's on the far left of this ECG tracing, which I think is always important to note when you see very high voltage, because you'll see this once a year, is the scale, right adjacent to lead 1 and lead 2 and lead 3. You see that little rectangle that's missing the bottom of it.
Mhm.
That is the scale, and it's a normal 10 millimeter scale. And so anytime you see super high volts, if that scale to the left is actually higher than or taller than 10 millimeters, that means that doesn't mean your LVH, it means your scale is off. And sometimes people turn up the scale because they want to see things like, yeah, I can't tell if there are P waves, so they turn up the scale, but that can also make everyone look like they have LVH.
Hmm. That's a really good point. So now let's sort of put these criteria to a test and go through an example. Take a moment to pause this video to go through this example yourself. So starting off, we have our rate, which is 140 beats per minute here. Our rhythm is sinus tachycardia. So we have a narrow, complex, regular tachycardia with P waves before every QRS and P waves of normal morphology, which is consistent with a sinus tachycardia. Um, we also have our P waves, which are of normal morphology. No evidence of atrial enlargement here. Our PR interval is actually really short. So if you look here, it's less than 120 milliseconds, and we'll get into why this could be the case. Our axis is normal. So we're upright in 1, upright in 2, also upright in EBF, so no axis deviations here. And then we see that our QRF complex meets LVH criteria. So here I'm applying the Sokolov-Leon criteria. And if you add these two, it's greater than 35. And you're also seeing some concurrent ST changes. So over here and over here, there are some T wave inversions and ST depressions in 3 and EVF. We also see some slight Q waves in these leads, and our QT interval is less than 500. So overall, this EKG is showing sinus tachycardia. We have evidence of LVH, some strain because of the ST depression and T wave inversions, and also possible LGL syndrome. So this is a hereditary syndrome that we can see with shortened PR intervals. Oftentimes with shortened PR intervals, we think of Wolff Parkinson White, but here we don't have our classic delta wave. So this is just a little fun tidbit as an aside, but not the main purpose of this EKG. Jason, anything else you'd want to add here?
No, I think it's just to nitpick the rate of 140. So yes, it ends up being sinus tachycardia, but when you determine that rate, that was the ventricular rate, which ends up
Mm-hmm.
being also the atrial rate
Mm-hmm.
as well. And yeah, there won't be a lot of ECGs you'll see with the PR interval quite this short.
Mm-hmm. So getting a little bit more into LVH with strain, which we saw in the last slide. Um, Anytime you have abnormal depolarization, you can see some abnormal repolarization. So what that can look like is that you can see ST depressions with a downward concavity and asymmetric T wave inversions in V4 and V6. And then you can see ST elevations that are of upward concavity with upright asymmetric T waves in V1 and V3. This is a lot of words basically to say that in areas where you have this tall R wave, you can expect to see some discordant changes with ST depression. So we're going in the opposite direction of our R wave. And in areas where you have a deep S wave, you can expect to see some ST elevations, discordant changes in the opposite direction that can be indicative of strain. However, you always want to consider ischemia. So ischemia is more likely if you're having like flat ST elevations or depressions, symmetrical T wave inversions, or a sharp J point. And you also have to consider the patient itself as well. Jason, any other tips to sort of differentiate ischemia from strain?
It's really hard. The best the best advice I can give is always look at prior tracing.
Mm-hmm.
Right? If someone has a tracing that looks different than before, then usually they haven't developed LVH within the two ECGs. That it's more likely to develop a new ischemic process, and obviously the clinical context that goes without saying is important as well. And yeah, anytime there's concord in ST changes, so for example, a predominantly negative QRS with ST depression or a predominant positive QRS with ST elevation, that's immediately a red flag
Mm-hmm.
for an acute ischemic process.
Let's go through an example. So starting with our rate here is 75 beats per minute. Our rhythm here is sinus. And then our P waves are of normal morphology, no evidence of any conduction delays. Our PR interval here is also normal. It's not too short, not too long. And then we have a left axis deviation. So if you look here, we're positive in one, but mostly negative in two, and negative in AVF, which is consistent with a left axis deviation. And then looking at our QRS complex, we note that it does meet LVH criteria. So here I'm applying the Cornell criteria, and the sum of this is greater than 28 or 20 in women. And you also can note that our QRS is a little bit wide, and you might think about a left bundle, but here the wide QRS is better explained by LVH. Additionally, there are a lot of ST changes. I've pointed out a few here. There are these ST depressions with T-wave inversions in 1 and AVL, as well as V5 and V6. And then you also have some ST elevations in V1 to V3. And note that these changes are mostly discordant. So anytime you have your deep S wave, that's where you see some ST elevations. Anytime you have your tall R wave, you're seeing some depressions and T wave inversions. There's no Q waves here, and our QT interval is normal. So in summary, this is showing us LVH with a strain pattern. Anything else you'd like to add, Jason, to this?
Yeah, this is a really nice classic example of discordant ST changes. The only two nitpicky things I'll say are if you look at the last four QRS complexes and the rhythm strip on lead 2 at the bottom, there is some irregularity. We
Mm-hmm.
actually talked about this in the first session. This is probably sinus arrhythmia again.
Mm-hmm.
Some irregularity with respiration. The second thing I'll say with the width of the QRS, yeah, I mean, I think it depends who you ask. When the QRS is just around hits 120, I think you can explain that by LVH alone. This
Mm-hmm.
is almost sort of starting to want to become a left bundle. If you wanted to write incomplete left bundle branch block, I think that's fine too. You're getting toward a left bundle, but the LVH with substantial LVH, you can start to get there as well.
Mm-hmm. So next, we're going to shift gears and talk a little bit about RVH. So RVH is often caused by pressure overload from pulmonary hypertension. And so when we're talking about RVH, we're going to go back to our same picture. So similar to LVH, you have the additional vector that's produced by enlarged right ventricle, and that's going to add to the normal vector that's pointing in this direction. So you can imagine that in the leads where this vector is pointing towards, you would expect to see a more positive deflection, and that happens to be V1 and V2. And this is the basis of the RVH criteria that you can expect to see an R to S ratio greater than 1 in leads V1 and V2. You can also see some strain with ST depressions as well as T wave inversion, similar to what we see in LVH. However, it's important to note that an R to S ratio in leads V1 and V2 greater than 1 alone is not diagnostic of RVH. You should also look for some other things. These include a right atrial conduction delay, right axis deviation, evidence of strain, and then our classic S1, Q3, T3. And this is because an R to S ratio has a broad differential if it's greater than 1. In addition to RVH, you can see this in a right bundle branch block, a posterior wall MI, Wolf Parkinson White, young kids and adolescents, and then also lead misplacement is something you have to consider. So I want to emphasize that identifying RVH is very challenging because you have to go through this differential anytime you're suspecting RVH. But we'll go through some examples that'll hopefully make some of these things clearer. So starting off with our first example, here we have a rate of 78 beats per minute. Our rhythm is sinus. And then our P waves, if you look in leads 2, they're actually pretty tall and greater than 2.5 millimeters. So this would be consistent with a right atrial conduction delay. Our PR intervals are normal and they're pretty consistent throughout. And then we have a right axis deviation here. So we see a negative component in lead 1, or positive in 2, positive in AVF, which is consistent with a right axis deviation. Your QRS is narrow and it also meets RVH criteria, and I'll go through why. So first we have our R to S ratio that's greater than 1 and leads V2. So now you're thinking about your differential for the R to S ratio. You also see this S1, Q3, T3 finding. So this, in conjunction with the right atrial conduction delay, right axis deviation, all of that is pointing you towards RVH. There's also some ST and T wave changes. There are these depressions and T wave inversions, likely some evidence of RVH with strain. We have some Q waves as well, like mentioned before, and then our QT interval is normal. So in summary, here we're seeing evidence of RVH with strain. We have a right axis deviation, right atrial conduction delay. Jason, anything else to point out here?
No, I really have no notes. This is excellent. This is right out of, like, you'll see this in, oftentimes in MICU or CCU in patients that with longstanding pulmonary hypertension that come in with heart failure or in the clinic. Really, this is a hallmark ECG in patients with severe longstanding pulmonary hypertension and develop RVH like this.
It's almost perfect. It has almost everything in here.
Yep.
Okay. Let's go through another example. So once again, here our rate is about 100 beats per minute. Our rhythm is sinus. Our P waves are upright in 2 and V1, but there is a possible right atrial abnormality. If you look here, these P waves here as well as in V1 look kind of tall. They're somewhat borderline, but could be a right atrial conduction delay here. Our PR interval is normal. And then we actually have a pretty far right axis deviation. So if you look, we're negative in 1, negative in 2, also mostly negative in AVF and positive in AVR, which is consistent with a far axis deviation. And remember, going back to our last session, anytime you see a far axis deviation, you want to make sure that it's actually a far axis deviation. So here we don't have inverted P waves, and we have other pathology in our EKG that could explain why we have an axis deviation that's this far right. So it's more likely a far axis deviation as opposed to some type of limb lead reversal. And then going through our QRS. So our QRS is actually wide and is consistent with a right bundle branch block. So we see that it's greater than 120 milliseconds. And then we have these slurred S waves in leads 1 and in V6. And while you might initially look at this EKG and note the R to S ratio, this R to S ratio greater than 1 is better explained by a right bundle. And one thing to point out here is that we don't have our classic bunny ears or RSR prime pattern for this right bundle, but it's still a right bundle nonetheless. Other things, we see a lot of ST and T wave changes here, so I've pointed out a few of them. Here we see predominantly discordant changes, so we're seeing ST depressions with T wave inversions, and all of in V1 to V4, also actually a little bit in V5 as well. And then we're seeing ST depressions and T wave inversions in 2, 3, and AVF. We are not seeing any Q wave specifically, and our QT interval is normal. So this EKG is showing us we have a right bundle branch block, far right axis deviation. We're seeing predominantly discordant ST changes, like I pointed out here, but you cannot exclude ischemia given the extent of these ST depressions and T wave inversions. Is there anything else you want to point out, especially?
Yeah, it's a really tough ECG. I mean, in terms of the far right axis, I think the QRS is predominantly positive in AVF, which gets you to the far right axis versus extreme axis.
Mhm.
Second of all, you have the right bundle, which can explain the RS ratio, but you can get a right bundle from RVH and from dilatation of your right ventricle and stretching of the right bundle branch.
Hmm.
So all the far right axis deviation with the right bundle, with the probable right atrial abnormality, probably this is a little trickier, but similar to example 3 of a patient with significant RV pathology as well, but it's just more of a frank right bundle in the setting of all these findings.
Mhm. Yeah, so this sort of emphasizes the fact that RVH is a really challenging diagnosis to make, and you can see that in all of these EKGs that we're going through.
But I think if right bundle branch block, we'll talk about in a future session, that's such a huge differential.
Mhm.
So when it's associated with right atrial abnormality and right axis deviation,
Mhm.
that should alert you that maybe it's not run of the mill right bundle branch block, and maybe there is something going on the right side of the heart.
Mhm. And this is just a brief aside I wanted to do on concordant and discordant changes. We've sort of been talking about it a lot, but I think it's helpful once again to sort of visualize it. Um, like I said in the last EKG, we were talking about predominantly discordant changes. So what that means is that if you have predominantly positive deflections, you can expect to see discordant changes in the opposite direction. However, if you're seeing concordant changes, that's more likely to indicate some type of pathology. So always to keep that in mind. Anytime you have abnormal depolarization, you can have abnormal repolarization. And then I just wanted us to go through one last example. I'm not going to go through all of this, the entirety of this AKG, but I wanted to point out here that we have, once again, an R to S ratio greater than 1 and V1 and V2 with some associated SP depressions. So going through our differential for this R to S ratio, first we might think about RVH. However, if you look, there's no evidence of right atrial conduction delay. Our P waves don't look super tall here. There's no right axis deviation. In fact, we have a left axis deviation mostly here, with being negative in lead 2 and mostly positive in 1. And there's no evidence of like our S1, Q3, T3. So this is less likely to be RVH. Then you might think about a right bundle, but our QRS complex is narrow, so that's unlikely. You could think about Wolff-Parkinson White. However, our PR interval is normal, it's not short. We don't see any delta waves. And assuming this person is a middle-aged person and our leads are placed correctly, what we're left with actually is a posterior wall MI because we've sort of ruled out all of these other things. And so it's really important in this situation to ask for an EKG with posterior leads. Just like a brief aside into posterior wall MIs is a preview into our ischemia session. But in a posterior wall MI, you have an infarction of this region. So you can see ST elevations in V7 through V9, and then you see these reciprocal changes in V1 and V2. That's in the form of a tall R wave, as well as with some SP depressions. Jason, anything else you'd want to add for us to be able to spot
Yeah,
these?
just go back to the prior
Hmm.
trace, right? So we think about these tall R waves as really just posterior cues because V1 and V2 are over the anterior part of the chest. And notice that there are ST depressions here in V1 and V2.
Hmm.
So just like those tall R waves can be posterior cues, those ST depressions can be posterior elevations. So
Hmm.
this is actually like probably an acute posterior wall MI. Typically, you'll see concurrent inferior Q waves and maybe ST elevations. It's kind of tough to see. I'm not really sure there are frank Q waves in the inferior leads here.
Hmm.
Um, but yeah, definitely it should be. This is one of the can't miss things because it can be an acute pathology. So
Hmm.
really, if you see a tall R wave, I try to think about, am I missing a posterior infarction? And when I can comfortably answer no, because there are maybe other signs of RV abnormality, or this has been a long-standing finding looking at prior tracings. Once I rule that out, then I can go down the road of the RV pathology that we previously talked about in examples 3 and 4.
Hmm. So just to summarize, we covered a lot of different things today. Um, the EKG changes that we see in RVH and LVH are produced due to an increased amplitude of the native vector. So if you remember our diagrams in the very beginning of our session, this will help you sort of remember some of the criteria. With RVH and LVH, you can often see concurrent strain, and these are seen in the form of discordant ST changes. You should definitely consider ischemia if you're seeing concordant changes or symmetrical T wave inversions. And then just a reminder that RVH is a really challenging diagnosis to make, and there's a broad differential for R to S ratio greater than 1. So this concludes the end of this session. We hope you'll join us in our next session on ischemia.